Welcome to Under the Sun podcast.
I'm Irene.
And I'm Ilea. We're so glad you're here. Grab a hot
or iced coffee and join us as we talk about everything under the sun. Welcome back to part 2 of our interview with Dr. Stu. Enjoy.
It's not hard. It's not hard to figure out. And the cognitive dissonance that comes into play. I use this example all the time. I'll use it again because it's powerful. The C-section rate in the United States is over 30%. In many countries, it's 50, 60, 70%. With, again, no concern for what that's doing downstream to the next generation or to this generation of women who have had the rite of passage taken away from them. They don't care. It's not part of a research paper. But let's just say it's 30% because I want to do easy math here. And the World Health Organization has been very clear for the last 40 years that C-section rates over 10%, maybe 15, do not improve outcomes. They said that a C-section rate of about 10%, you improve outcomes going up to that point. It used to be 5%. They said they've improved outcomes going up to 10%, but beyond 10%, there's no improvement there's no evidence that there's improvement in outcomes by raising the C-section rate. Yet it's obviously raising. So let's just say 15%. Let's give the World Health Organization the benefit of the doubt. Not an organization I have much respect for. But this was 40 years ago before they turned into the absolute tyrants that they are now. So they say 15%. And let's say in the United States, the rate's 30%. Well, that's easy math. You can see where I'm going with this. There's about 1.2 million cesarean sections done every year in the United States. It's by far the most common surgery performed, far greater than any of the major orthopedic surgeries or anything else. Far greater. But that's about 30%. But if it should be 15%, that means 600,000 women every year in the United States are having unnecessary surgery. Now, you could argue the numbers and blah, 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 but we know that there's a lot of unnecessary C-sections being done. And in countries that have rates that are 70 and 80%, you do the math, it's like ridiculously amount of women having unnecessary major abdominal surgery that puts them, their baby, and all their future babies at greater risk. And that's going on every day in the United States in every hospital. And 30% is being kind. Many hospitals have 40 and 50% C-section rates. So here's the thing. If there were 600,000 unnecessary knee surgeries being done or gallbladder surgeries or mastectomies or anything like that, not only would people be outraged, but insurance companies would be outraged because they're paying for these things. Yet we don't hear a peep from the insurance companies when we know that there are at least 600,000 unnecessary C-sections being done in the United States. And people can quibble with the math, but you can't deny what I'm saying. You just can't. So, because it's not possible that 50 years ago we had a C-section rate of 5%, and now it's 30-some%, and that all those are necessary cesareans. Right. So.
But aren't we better at diagnosing?
No. No, because outcomes are worse.
I know.
Again, it's not hard.
I know.
This is not hard inductive logical argument. But here's the question. If there are 600,000 unnecessary C-sections being done every year in the United States, who's doing them? Do you know anybody that's doing unnecessary C-sections? No. Because no doctor ever goes home at night and says to their spouse, hey, honey, guess what I did today? I did 2 unnecessary C-sections. No. Every C-section a doctor does, he or she believes is necessary. Yet half are unnecessary. That's classic example of cognitive dissonance. And when you are being ruled by confirmation bias and cognitive dissonance and mass formation psychosis, you can't make change. You just conform. Why did doctors go along with the COVID vaccine?
They don't know how to question anything.
Right. Why did doctors ostracize people that they had shared coffee with for years? They drinking buddies, bowling buddies, softball buddies. They ostracized them suddenly. You go back to Nazi Germany, and how is it that within a matter of 6 or 7 years, there was always anti-Semitism, but Jewish families lived lived together. I'm trying to think of the word. Lived together in the same neighborhoods. They sent their kids to the same schools. The kids played in the same streets. Suddenly, within a few years, not only were they turning their neighbors in to the SS,
Mm-hmm.
but they were going into their houses and stealing their furniture and their belongings as well.
Mm-hmm.
And in COVID, people that used to have block parties together,
Mm-hmm.
people that used to go to the soccer games together and sit on the sidelines and cheer for their kids together, suddenly that neighbor is turning in the other neighbor because they've got more than 4 people in their backyard.
Yeah.
Or little Johnny's playing on the front yard without a mask on,
Mm-hmm.
or whatever. And so how does that happen?
Yeah.
How do you take good people who loved each other or liked each other and suddenly turn them against them? And that is a psychological thing called mass formation.
Yeah.
And we've seen it, and about 70 to 80% of people are easily subjected to that. One of the things I talk about is something from the 50s called Ash's conformity experiment. And it's a simple experiment. You show he took 12 people in a room and he showed them 2 slides. One slide had a bar that was a standard length, and the other slide had 3 bars of 3 different lengths. And this bar matched one of the 3 bars, A, B, or C. And they would ask the 12 people, does this bar match A, B, or C? And everyone would say C, 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 all along the room. After about the 3rd time, 11 of the people of the 12 people were in on the deal. And there was one subject for the thing. And the 11 people started to say the wrong one.
Mm.
It was obvious that it was B, and they would say A. A. And after about 3 rounds of that, the one subject, 75% of the time, would say something that he knew was wrong, but they say it so that he be part of the group.
Wow.
Yeah.
This is how our brains work.
Mm-hmm.
And it's why people were so easily coerced and why some people weren't.
Mm-hmm.
Like I said, there's about 20% of us or 30% of us that resisted incredible pressure to conform during COVID,
Mm-hmm.
that missed out on births, funerals, weddings, bat mitzvahs. We were not invited to the things by our family. We chose to stand our ground.
Mm-hmm.
Why did we do that? Who are we? And why aren't those people the ones in medical school? And this is the theory that was brought to me by one of the midwives at one of my seminars, because I always thought that it was medical school that just beat the shit out of you and you just gave up.
Yeah.
And you turned somebody who was a shepherd into a sheep.
Mm-hmm.
And she said something really important to me. She said, no, medical schools are weeding out the shepherds and they're not letting them into medical school anymore.
Mm-hmm.
They're looking for sheep.
Yeah.
Which is something that's profound if you have to think about it. And I don't know whether it's true or not.
Mm-hmm.
But when I went to medical school, and I sound my dad who walked 12 miles through the snow uphill both ways barefoot.
Yeah. Right.
But when I went to medical school, people went to medical school because they wanted to be captain of their own ship. Obviously, they wanted to make a lot of money and prestige and all that other stuff, and we had big egos. That's true. But we wanted to be we were willing to be captain of our own ship. We were willing to take responsibility for the decisions that we made and for the women or the patients. If you're a doctor, not all doctors only take care of women, but we did. We were willing to take that responsibility.
Mm-hmm.
Now, you don't have an obstetrician who will pick his nose without consulting with a maternal fetal medicine specialist first.
Yeah.
Mm-hmm.
We were trained in all things obstetrics. If a woman had hypothyroidism, we would deal with her synthroid or whatever.
Mm-hmm.
If a woman was diabetic, we would take care of her diabetes. One of the things that happened with that was that insurance companies stopped paying OBs to take care of diabetic women.
Mm.
So I could take care of diabetes. I was trained to do that. But if I took care of it, I got paid nothing extra. If I sent her to an endocrinologist, he got paid to take care of her diabetes.
Yeah.
So why am I going to spend time taking care of her diabetes? And so we got, with lack of a better word, we got castrated.
Yeah.
Mm-hmm.
OBs got castrated. And because the people that are teaching OBs in residency programs are generally maternal fetal medicine specialists, whether they mean to or not, they're basically disempowering these doctors to be and making them become dependent on maternal fetal medicine specialty, which creates a lot of business for maternal fetal medicine doctors and perpetuates the thing. It's kind of like having lawyers become politicians who then go to their state capitals and make laws that require you to have more lawyers
Yeah.
to manage the laws,
Yeah.
to stay within the law.
Yeah.
there's something very corrupt and sinister about that whole thing.
Meanwhile, they're like, oh, you guys don't ask questions. You, as the women, as the families, like, don't even question your doctor, because if you do, it's, you're not trusting the science. You're not trusting their schooling. You think your Google degree is gonna, like, there's the disempowering of the OB side, and then the disempowering and like, we're also being castrated in some sense of like anything, any type of, if you question it, it's like, oh, we have this difficult patient in room 4, and it's like, what? No wonder women, I think, are flocking to home birth and birth centers.
I wish they were flocking. Let me ask you this question. Here's a simple question about high risk. It's like, which is riskier? A woman who questions what her doctor's saying, or a woman who follows everything her doctor says?
I think
the
latter. The second.
Right, but which one's labeled high risk?
Oh yeah, the first one for sure.
Correct.
Oh yeah,
right.
Yeah. And they'll put a note in the chart that
They'll
you're
call
difficult.
Her non-compliant, difficult patient.
My daughter had to get stitches, and it was 2 a.m. We got there at 9. We could have been out in 20 minutes, but we had to sit in this room where I got flanked because they can see my medical chart. I had 3 doctors come in. One sat on the bed and one stood on each side. It's 2 a.m. We're all tired. My child is 4. She's terrified. She's half asleep. To push that I get a tetanus vaccine. And I was like, she cut herself on glass. We're good. And they really because I'm aware you're not going to like full court press me into taking a vaccine for rusty implements when she cut herself on glass. Stitch her up so I can go home. I shouldn't have to go into the emergency room feeling that pressure
with
of like
cortisol, fight or flight.
And then I did get my like chart back, so I'm reading it, and the wording they put about me being, they didn't say not compliant, but the wording was very condescending about how I rejected their
there's multiple basic tenets in medical ethics that dictate that given the same information, it's not reasonable to expect all patients to come to the same conclusion, and that a decisionally capable person has the right to accept or deny treatment. But they don't believe in that. They don't believe that if you don't do what they say. Now, I'm surprised that because your child had a cut, that they didn't call in Child Protective Services, because maybe you were cutting your child.
That every time something happens, that is in the back of my head.
And we talked about this before we went on air today, about the idea that the people are becoming afraid now to take their child to the hospital because of this tyranny that's going on. By the way, ACOG has a very strong statement against the use of coercion of any kind, including calling Child Protective Services. And so one of the things that I would always tell women who are listening, when they go to their doctor and their doctor's telling them something they don't agree with, or that they want a different one, just ask your doctor, doctor, do you believe that ACOG is your guiding society? Yes. Do you follow ACOG guidelines? Oh, of course we do. Then you pull out ACOG guideline number 664, which is the one on guiding you as far as consenting and ethics. And you say, how come you're not following this one?
Love
that.
And
that's great.
And be nice, be polite. You could be a little bit snarky, but you don't have to be, but challenge them. They're too comfortable with their head in the sand in the world that they live in. And they think they're protected, and they think they're doing good, and they're not doing good. How do I know they're not doing good? Just look at outcomes. Always goes back to outcomes. I don't care if your intentions are bad, but your outcomes are good. I'd take that over somebody with good intentions who keeps having really worsening outcomes. If nothing else people don't remember anything from this podcast we're doing today, that's something they should remember. I used to listen to a guy on the radio, Dan Bongino, before he became deputy director of the FBI. I would listen to his podcast sometimes. So I want to give him credit for this. But there's a movie called Moneyball. Maybe you've seen it. It's a guy movie. It's a baseball movie, but a lot of people see it. Brad Pitt's in it. And there's a scene where Brad Pitt plays Billy Beane, the general manager of the Oakland A's. It's a very quick scene. It takes place in the coach's room downstairs. He's talking to these scouts, and the scouts are raving about this hitter in the minors. And this isn't a focus of the movie at all. He just says this one-liner. He says, if he's such a good hitter, how come he doesn't hit good?
Hmm.
And that's what I would use that example.
Yeah.
If your model of care is so good, how come it isn't working so good?
Yeah.
Ask your doctor that. And don't be gaslit by saying, well, women are fatter and women are older and we have more toxins in the world right now. Well, if we do have more toxins, how come you're telling me to get 5 vaccines while I'm pregnant?
Yeah. Yep.
But don't eat sushi.
Yeah.
Oh, or deli meat.
Yeah.
No.
Right.
They did. It is funny because they asked multiple times throughout that process of her getting stitches. They seemed shocked that she wasn't on any medications. So she's not on any medication. I'm like, no. And then someone else, so she's not on any medication. I'm like, no, she's 4 years old. What does she need? But it surprised me as I was thinking about it in hindsight, how shocked everybody was. Like, why are you expecting my 4-year-old to have a laundry list of daily pharmaceuticals?
See, what happens to these people, and some of them wake up, and you hear stories about some labor and delivery nurse or some ER nurse that just says, I can't take it anymore, and they quit.
Yeah.
But most of them are of that 70% of the mass formation who just, the idea that they want to be part of something and believe what they're doing is good makes them into a person that thinks like that.
Yeah.
That doesn't think there's any other way to do things other than the way that they've been doing things in the ER for so long.
Yeah.
Right. The idea that you need a transplant. You can't have a transplant until you get a COVID shot.
Yeah.
That and that everybody doesn't rise up and say that's crazy. No, the mainstream medical model thinks that that's okay.
Yeah.
We just interviewed a mom who her child has like kidney disease because of a vaccine he got when he was 6 or something.
So.
And now they have taken him off the transplant list because he won't get the COVID vaccine. And so like he is not getting the things he need because he's not like his mom is not compliant and they've been late. Like it is their story is terrible. Like it's horrible, the gaslighting that has happened. But okay, I do want to get to some what is high risk?
This all started because you asked me how I got to do what I was doing.
know. No, it's amazing.
I love it. Well, I want to also make sure we talk about you when we had to cut for the cards, talking about the masculine energy, because you are a home birth like person, but that was interesting. So
go ahead. You can start with that.
Do you want to just go with birth for now?
Well, I feel like the scope of high risk, the label of high risk has like broadened so much.
Yeah.
And like some women I know love the attention. I feel like that comes with like, oh, I'm high risk, so I have to go to like all the time. And I'm like, what has happened that the scope has gotten so big that everything is such a risk? Like, are we afraid of birth? Like, pregnancy is not an illness. Why are we seeing it this way? Is there like anything you can say to that?
Yeah, it gets back to the thing we talked about earlier. If you can label a woman high risk, you're going to make her fearful. She's going to do whatever you want you to do.
And
it's about control.
Yeah.
I have a really good talk about high risk. I'll just try to summarize it really quick. High risk is not a number.
Yeah.
Because as I just told you earlier, there are many things that the doctors will suggest because they think something's high risk, but the suggestion they will give you is higher risk. Classic example, because breech is so dear to me, is breech birth in the medical community, and because they projected it outward, is like, oh, this scary thing where the baby's head will get stuck and the cord will fall out and the baby will die and all that other stuff. That's actually not true. Properly selected breech birth vaginally with a skilled practitioner is almost as safe as head down vaginal birth. Okay. The Royal College of OBGYN has the numbers, and the neonatal death rate, they've rounded them to is 1 in 1,000 from a head down birth, and it's 2 in 1,000 from a breech birth. Wow. So basically 1 extra baby for every 1,000 births. But the medical model would believe that we need to section 1,000 women to save 1 baby, but they wouldn't section 1,000 head down babies to save 1 baby.
Yeah.
So what are they talking about?
Yeah.
They don't know. So breech birth is one of those things where they'll label it high risk. But I would ask this question: what's riskier, a woman having a vaginal breech birth, or a woman having a C-section for breech who wants 2 or 3 more kids?
Yeah. They don't tell her.
No, because it's a live baby in the bassinet, and downstream stuff doesn't matter.
Yeah.
But I'm just telling you that the latter is much riskier, because now not only have you put the mother at greater risk from a surgical birth,
Mm-hmm.
but you put the mother at risk of placenta accreta or other things in the future, of bowel obstruction, of other things that go with major surgery.
Mm-hmm.
You've also put her future babies at risk, because now they have to deal with the whole VBAC, scarred uterus, ruptured uterus issue down the road. So it actually is safer for a woman to have a vaginal breech birth with a skilled breech practitioner, properly selected. Again, not all breeches are safe to be delivered vaginally, but a skilled practitioner will know that. Unfortunately, most OBs are not skilled practitioners anymore. They don't know anything about breech. Immediately, they'll give you the only one choice, which is, again, unethical, because they're not giving you full informed consent. They're not giving you the idea that an ethical thing would be to say, Irene, I don't do breech delivery. I'm not comfortable with it, but I know some people who do. Why don't you go have a conversation with them?
Yeah.
That would be ethical. But to tell you, oh, breech is dangerous and nobody does it and only idiots support breech birth, and you should have a C-section and we need to do it before labor starts, because if labor starts, the cord could prolapse and then you'd really be in trouble. And I mean, this is them vomiting their own anxieties and fears and misinformation. And I hate that term, but onto you.
Yeah.
So high risk is not a number. High risk is something that makes your physician uncomfortable. That's what you have to look at. All right. And then what happens is once you're labeled high risk, that changes your own brain chemistry. So now for the entire pregnancy, instead of secreting dopamine and oxytocin and enjoying yourself, you're bathing your baby in cortisol and adrenaline, and not of the love hormones, but of the stress hormones.
Yeah.
And what is that doing to the epigenetics of your baby that's developing inside of you? And how will that affect that baby when it grows up and maybe it wants to have children, that sort of thing. No one knows, no one's looking.
Yeah.
But you have to understand that we're all connected. Nature didn't do this in a vacuum. It designed a system to propagate our species and to make us strong. And the idea that only medicines can save us from ourselves is such hubris that I don't even know where to begin. So there's an advantage, especially for the maternal fetal medicine profession, to get more and more women to think they're high risk, because God, that creates a huge amount of business.
Yeah.
And so there's a huge conflict of interest there. And the fact that OBs have fallen for this and basically treat every woman on an algorithm. In other words, every woman who's got twins needs to be treated the same. If you got di twins, you're treated this way. If you got mono-di twins, you're treated this way. If you have diabetes, you're treated this way. If you have cholestasis, you're treated this way. It's like, no, every woman is an individual. Some women with diabetes need to be managed carefully and need to be delivered early. Most women with diabetes, especially today where women now with diabetes have continuous glucose monitors and insulin pumps and stuff, they can just push buttons and control their insulin, are very tightly controlled and probably have better glucose control and better hemoglobin A1C than most of you listening. But because they're labeled a diabetic, they're going to be treated as a high-risk patient who needs to be fetal testing twice a week from 32 weeks and maybe be induced at 38 weeks or have a C-section because they think their baby's too big. Again, the positive predictive value of ultrasound to predict fetal weight is horrible. Shouldn't be done. ACOG even admits that doing a cesarean section for suspected big baby is contraindicated. Yet that ACOG guideline they will ignore. So I've gotten to the point that you could come up with things where I could give you specific numbers on things, but high risk isn't a number. High risk should be determined by what the individual woman feels, given true and honest advice and not skewed advice. Listen, we all have a bias. When I advise women, I'm very clear that I have a bias, but I also try to give as much information as possible. And the reason I can do that partially is because my model of care when I was practicing was that I had time to do it. Again, another flaw in the medical model, which doctors have just bent over and taken, excuse the metaphor, is that they don't control their own schedule. Because the reimbursement is so poor, they have to do volume. So they have a prenatal visit that's 8 minutes long.
Wow.
You cannot do in 8 minutes what a midwife does in 60.
Yeah.
You just can't.
Yeah.
And if you're a pregnant woman and you want good care, you may love your doctor. He or she may be a really sweet person. They may be great. But again, they may not have the time to give you the information that you need or to answer your questions. And how do you feel when you're leaving the office? Do you feel satisfied? Do you feel like better than when you came in? You're always a little bit nervous when you go to the doctor's office. Are you feeling better when you leave or worse? And is that doctor going to even be the one that's on call when you're in labor?
Yeah.
And what happens when you call at night with a question and you get a doctor who's had a bad day, who's not your doctor, doesn't know you, who rolls his eyes exasperated and says, you know, I really don't know what's going on with you. You need to go to the hospital.
Yeah.
Whereas your doctor could have said, oh, Jane, that's fine. Don't worry about that. Just call me in the morning if it's still bothering you. We'll take a look at it. And that makes you feel better.
Right.
Yeah.
This is all part of medicine. And it's not part of the medical model that currently being practiced. They've lost touch with the humanity part of it.
How do you feel like then, talking about what you were saying with pivoting to home birth, how does it look now? Like, what is your perception on birth now? Like, yes, I also have a bias. I do not like hospitals. I don't like them in any sense. I want to hear how now home birth has,
like, the positives
the positives have changed you and your brain chemistry and your training.
There's no comparison between the two. If you want to have a birth that is natural, if you want to have what's called a physiologic birth, to quote Marsden Wagner, may he rest in peace, from the Business of Being Born documentary, if you want a physiologic birth, if you want to have control of your birth, stay the hell out of the hospital. That's what he says.
Yeah.
And he's not kidding. Now, here's the dilemma. Maybe 10 or 20% of women need hospital birthing. But the hospital needs 98% of pregnant women to go there in order to keep their doors open.
Yeah.
So, but they don't know how to allow a woman to have a physiologic birth because they have too many cooks making decisions who don't know about birth. The policies that are put in place there are put in place by maternal fetal medicine doctors, who a lot of them who don't deliver babies anymore. They're put in place by hospital administrators. They're put in place by risk management lawyers. These are the people that decide on the policies. And so when you go to the hospital, you are being told what to do by people who don't understand physiologic birth. So even if the hospital were to say, we're going to be more mother-baby friendly, or we're going to make our hospital more home-like, what that means really is that they're going to put nicer curtains and hardwood floors in the room. And the mother-baby friendly will be something that is great as long as you're still healthy or that we don't have COVID.
Yeah.
The minute COVID hit, the idea that mother-baby friendly, that issue went out the door. That you couldn't have the people there that you wanted to, and we would leave you alone, and you'd have the golden hour and all that other stuff. They don't do that anymore. They don't know how to leave you alone. Yeah. Here's a good example. Hospitals have protocols, and if a nurse doesn't follow the protocols, a nurse is going to get yelled at. But here's a silly protocol. You come into the hospital in labor and delivery, you're perfectly fine. They check your blood pressure, which is perfectly reasonable. It's 110/60. You're in labor now. You're perfectly fine. You're not feeling lightheaded. You're not complaining of a headache. You're not getting an epidural. Nothing. Your blood pressure isn't going to suddenly become really low without symptoms or really high without symptoms. That's going to require anything. Yet, how often are they taking your blood pressure while you're in labor?
It's usually like on all the time.
Yeah. Well, they wear the cuff, and then every hour or every 2 hours or every 30 minutes or whatever, it pumps itself up. Why are they doing that? Is there any thought process to that at all?
Litigation.
Well, that's what they say. But ultimately, it's a disruption. It's taking a mammal from its normal environment and interrupting it. It would be like your dog is in labor, and every 30 minutes you go into where the dog's laboring and you strike a gong. Gong!
Yeah.
And then you walk out again.
Yeah.
Yeah.
How is that helpful?
Yeah.
So again, the thinking is there isn't any. This is how we do it. This is our protocol. I mean, how many times have I heard somebody write to me saying they've asked the nurse why they're doing it, and the nurse's response is, it's our protocol.
Yeah.
Policies and protocols are not laws.
Mm-hmm.
Yeah.
And most of them are put in place by people who aren't there during the time dealing with it.
Mm-hmm.
Taking your blood pressure every hour while you're in labor is an idiotic thing.
Mm-hmm.
Doing vaginal exams in labor is an idiotic thing.
But how do you know when she's going to be ready to push? Dr. Stu.
She'll tell you.
Yeah.
I know.
And if there is a question, then you could check it. But doing a vag exam every hour or two so you can plot them on a curve.
Yeah.
Mm-hmm.
By the way, this is something that I want your listeners to understand. This is how doctors think. They've lost, they can't even understand basic geometry. How do you draw a curve? A curve is the mean of a bunch of scatter points, about a bunch of data points. That's what the curve is. So there's this thing called the Friedman curve, and it's been around since the late 50s, early 60s. And it's called a labor curve. And there's one for first-time moms called primips, and there's one for multips. And primip labor curve beyond 4 centimeters, maybe they've changed it to 6 now, but it's still like beyond 4 centimeters, a primip should dilate at least a centimeter an hour. This is what they found. And how do you know if they're dilating a centimeter an hour? Well, you had to do a vaginal exam every hour. And that's when I was a resident, we had to update the board every hour or two. We had to go around to all the women laboring, put a glove on, tell them this is necessary, lie to them, and do a vaginal exam. Because if we didn't have updated vaginal exams on the board, our chief resident would come along and yell at us.
Mm-hmm.
Why was he yelling at us? Because he was told to yell at us.
Yeah.
There's no thought process.
Yeah.
But here's the crazy thing. Think about the geometry of that curve. Because what you're told, if you're not dilating fast enough on that curve, you need to be intervened upon, which would either rupture membranes or start Pitocin.
Mm-hmm.
But if you look at the curve, how many women are below the curve? Anybody know?
Mm-mm.
50%.
Wow.
That's how a curve is made. It's simple math. The curve is the median. So 50% of women are below the curve, 50% of the women dilate faster than the curve. The curve is the average.
Yeah.
So if you're
just
telling,
stop tracking it, just leave it.
well, listen, but if you're telling a woman that she's falling off the curve and that you need to intervene, you're basically telling 50% of women that their labors are abnormal.
Mm-hmm.
Yeah.
Does that make any sense to anybody? Why did Dr. Friedman not understand that? What am I missing?
Mm-hmm.
Somebody comment on this podcast and tell me what I'm missing, that half of the women are going to be below the curve and they're going to be labeled as their labor is dysfunctional.
Well, and then
when it's perfectly normal.
Yeah.
Where did we come up with the idea that labor is on a watch?
Mm-hmm.
it plants a seed in then women's minds for subsequent deliveries that something about their body is broken, because last time I stalled, last time I didn't do, so they had to break my water. And then, oh my gosh, the heart rate tanked and it was so traumatic. And they saved me by pulling out the baby with forceps. And like, it's just.
Yes. And the problem is, Ilea, is sometimes that's true, but most of the time it's not.
Yeah.
And we are being gaslit to believe that that women have to be managed in order to have a safe pregnancy. And by the way, that just builds up the necessity for the industry itself.
Yeah.
It's a self-perpetuating thing. But the truth is, again, if that was so true, then why are our outcomes not getting better?
Yeah.
Yeah.
Why? Now, I this is a radical statement. I don't mean it. It's not going to happen. But I would tell you, if we would probably have better outcomes if every pregnant woman had never had an ultrasound.
Mm-hmm. Yep.
We would miss some things and we would have some bad outcomes. But we certainly wouldn't have all the stupid interventions because a baby's on the smallish side, or the fluid is on the smallish side, or the placenta is looking old, and all these interventions that are being brought in that end up bringing you in for an induction, falling into that cascade of interventions, baby being taken back for an emergency C-section, getting a good baby out, and everybody's saying, wow, like you said earlier, thank God you were here, because what would have happened if you'd been at home?
Yep.
Yeah.
It's the same people that are doing these things over and over again, like taking your blood pressure and just basically saying, well, this is how we do it.
Mm-hmm.
Stop and think for a second. Why are you taking a brand new baby to the warmer? Many hospitals still do that. First thing that happens is the baby's cord is cut. Maybe they'll give you 60 seconds of delayed cord clamping because ACOG says 60 seconds. Where did they come up with 60 seconds? They pulled it out of their ass. They made it up. It's a made up number. There's so many made up numbers. 24 hours of ruptured membranes, age for 35, 42 weeks. These are all made up numbers.
Yeah.
But 1 minute delayed cord clamping is one of these stupid, but they're all made up, like 6 feet apart was made up.
Yeah.
Yep.
They're all made up.
Yeah.
So they allow 60 seconds of delayed cord clamping. Then they cut the cord. Then they take the baby over to the warmer. Why in God's name would you do that?
You have a human warmer right there. That was like God designed.
Yes.
Have that baby
And not
on the
only
chest.
that, if the baby needs a little bit of help, do it right here.
Yeah.
Do it on mom's chest. There are proven protocols that you can resuscitate babies on mom's chest or right next to mom's chest. If people would take NRP, they teach this. You know, neonatal resuscitation. What's the P stand for? Program, policy.
Amy just did it like a couple weeks ago.
Yeah, I don't remember what the P stands for, but NRP. And they teach you how you can resuscitate a baby with the cord intact, right on
Which
or
why
next
would
to
you
mom.
not do that? Because like in theory, like the placenta is still
they're still
attached in
getting
there. You're still
oxygen.
getting oxygen. They're getting their blood. So
If
like
they've got a heart rate, they're getting oxygen.
yeah,
Correct.
like within the cord, right?
Yeah, it's
within
it's
the cord, yeah.
circulating, right?
Yeah. Well, it's also because hospitals do sell off the placenta and they make a good amount of money off of your placenta.
I would love somebody, a whistleblower, to come forward. I don't know if there are some that have come forward, because I do wonder that. People have told me that a placenta has more value if it's delivered by cesarean than if it's delivered vaginally.
Oh yeah.
Yeah, that to me.
My dad, who had before he had his knee replacement surgery, had
Stem cells.
Stem cells all, and he was like, "Oh, they're all from placentas," and I'm like, and then that's when I did the deep dive into placentas, and I'm like, "Oh, they sell them." No wonder they're like, "No, it's bio waste. You can't have it." Because they sell,
That's
they
a
can
lie.
make
By the way, that's a lie.
it is a lie, and I'm like, just take your cooler. If you're gung ho about having a hospital birth, like take a cooler and just be like, no thanks, I'm putting it in.
By the way, here's an interesting thing about hospital policies and people. If you have a bloody tampon, or if you have a 4x4 or a Band-Aid in the hospital that's got blood on it, it has to go into that special red bag in one of those special buckets.
Yeah.
If you have a bloody tampon or a bloody Band-Aid or a bloody bandage at home, where does it go?
In the garbage.
In the garbage.
Yeah.
So, again, who thinks this stuff up? And by the way, in our office, when I was in Century City with our big office, we had to separate our garbage out. The hazardous waste garbage was a lot more expensive to get rid of. We had to pay a lot more money for that.
Yeah.
Yet at home, you can throw your
throw it
boogers and your vomit and
yeah.
your blood. It goes right in the garbage, or you flush it down the toilet.
Yeah.
Right. That's okay. But doing it in an office, you can be fined thousands of dollars if you don't separate out your trash.
Yeah.
It's kind of like the same thinking that you stand 6 feet apart to check into your airplane.
Yeah.
And then you get on the airplane and you're sitting 1 foot away from somebody who's coughing and sneezing, wearing a mask, but you take your mask off to eat your peanuts.
Yeah.
Yeah.
Mm-hmm. Oh yeah.
Those are the same people that are deciding all these other things. And
That's why nobody trusts. Like the people who are awake, nobody
70%
trusts.
of people still trust them.
70?
Yeah, I think so.
Do you think
I
they
think
trust,
in my
or are
family
they
it's
too
about
scared
90.
to stand
My
up?
family it's about 90%.
Yeah. I mean,
They don't listen. They don't listen to me.
I
My
have
family doesn't listen to me.
sisters who don't talk to me anymore since COVID. Because like I was trying to kill my parents and grandparents, and I was like, no, this just doesn't make sense.
Just think of the evil that Fauci and Deborah Birx and those people did by spreading that information that you're going to kill grandma. No, it's better that grandma dies by herself.
Yeah.
Without the touch of another human being.
Yeah.
Because we're going to save grandma by letting her die by herself.
Yeah.
Yeah.
This is what I'm saying. This is why I'm calling it low-hanging fruit.
Yeah.
If I was a satirist, if I was a comedian, this stuff is gold.
Mm-hmm.
Yeah.
Right. And now finally comedians are not being canceled for saying this stuff.
Yeah.
You know, if you were Dave Chappelle, you could get away with it back then because you were so famous. But smaller comedians, they got canceled.
Oh yeah.
But now they're hopefully making a comeback. And so hopefully will common sense in this sort of thing as well.
Yeah. Mm-hmm. Did you have any breech or twin questions before we wrap up? Because we got to get out of this Airbnb for here in about 15 minutes. But okay, so then for the moms listening, we'll just do some quick like rapid fires for the moms listening. If they have twins, are Are they immediate C-section because now they're twins?
No, and the American College of OBGYN says cesarean section. I mean, again, I'm cherry picking my ACOG guidelines
Sure.
too, but twins is not an indication for cesarean section, just in and of because it's twins.
Okay.
There are certain indications where twins should be delivered early, and there are certain indications where twins shouldn't go through labor. But most twins should be delivered vaginally. And the literature, if you really want to know about it, the world literature says that twins down to 1,500 grams, which is about 3 pounds, 5 ounces, which is about 32 weeks.
Okay.
As long as the twin A is in a stable longitudinal lie, which means either vertex or a proper breech presentation, there is no benefit on outcomes to mother or baby, and actually a detriment to mother, but there's no outcomes benefits to baby by doing a cesarean section for those babies. Yet, 80 to 90% of preemie twins will be sectioned, and almost all breech first twins will be sectioned.
Wow.
Yeah.
Simply because doctors have been indoctrinated to believe that breech is dangerous, and they don't know the literature. And again, they're cherry picking their data.
Yeah.
The term breech trial was a horrible piece of research. It should never have gotten through peer review. It wouldn't have gotten through peer review if it wasn't what this shows the corruption in science. And this was 20 years ago. The ARRIVE trial also had significant flaws into it, yet it was immediately accepted because it met the model by which doctors wanted, or those in charge wanted to practice. And this is the difference what science used to be. Science used to be, I have a theory, I'm going to study it, I'm going to randomize it, I'm going to see what happens, and I'm going to print whatever happens.
Right.
Now it's, here's where we want to be, here's what we want the science to show. Let's find science that shows what we want to show.
Yeah.
This is a corruption of science. So when people like stupid Dr. Fauci say things like, I am the science, or the science is settled, people, that's a clue, like the term
Run away.
that's a clue, that's like the term misinformation. Anybody who uses that term regularly to vilify somebody else that's spreading, that is a clue that that person is lying.
Yeah.
Because there's no such thing as misinformation.
Yeah.
If I'm telling you something that's not true, that's called a lie.
Yeah.
If I'm telling you something that you don't happen to like, well, that's a difference of opinion.
Yeah.
Misinformation is a word that they created.
Yeah.
Like provider, another word I hate. Okay. What does provider mean? It's become accepted now. Everybody, even my friends, Bliss even, uses the word provider. I've given up on trying to correct it. But provider is a generic term that diminishes the degree that you have. You're a midwife.
Yeah.
You're a PhD. You're a DO. You're an MD. You're a doctor. You are not a provider. I mean, the guy that makes my sandwiches at Subway is a health provider because I'm having a healthy sandwich. So he's a provider of my sandwiches. This is what I'm mocking the term. The term was created by insurance people to diminish the idea of the doctor-patient relationship, because the doctor-patient relationship was in the way of them taking over managed care. So they've now generically, and now you guys who are midwives, you're not even providers, you're mid-level providers.
Oh, geez.
This is what,
But yet they're actually doing the most in the form of care. Like my midwife appointments with Amy are like an hour long. She talks to me about everything from like health concerns to like emotional, like, hey, like how you prepping? Like, what's your vision for this birth? Like they're doing the most. And yet they're the ones who are the most like thrown under the bus, or the most, like we mentioned, she was just on our podcast a couple of weeks ago. And I was like, there's so many people who go into the OB's office and they're like, they don't ask any questions of the OB. What's your C-section rate? What's your episiotomy rate? Like how, like, are you going to induce? Like, when do you like to induce? Whatever. But then they go to like a home birth midwife, or I say I'm having a home birth, and people like, they're like, but like, what happens if this happens? It's like, well, you wouldn't say that if I said I was giving birth at, I don't know, St. Francis up the road. Like, you wouldn't say that.
no, they don't ask the
so
question.
like I feel so bad for midwives and people who are doing alternative care. Not even alternative, original. What do we call it? Like
Traditional.
traditional care. It's like, it's such a shame.
Well, getting back to the question about twins and stuff, it's twins vaginally is better for the mom, it's better for the babies. It just requires certain skills. Unfortunately, they're not teaching those skills anymore.
Yeah.
And those skills are how to manage a breech delivery should one of the babies turn breech. And we know, statistically speaking, that more than half of twins will have one of the babies will be breech.
I was just going to ask that. What's the ratio of,
It's about,
breech?
well, if you look at the data, it's about 53% of twins will have at least one twin in the breech presentation. And since OBs don't know how to do breech anymore, they're not going to offer you a vaginal delivery. So this is one of my huge pet peeves, because if you know that the woman has twins at 12 weeks, you do a scan at 12 weeks, oh, you look at you got twins, and you're not accomplished in breech delivery, and you know that more than half of twins are going to have a breech baby at term, then you should say to that woman, wow, Ilea, congratulations, you're having twins. But I don't know anything about twins, and I'm not an expert in twins, so I'm not your person. You need to go find somebody who is an expert in twins to help you.
Yeah.
But they don't say that. They skew their counseling to keep you in their practice, thinking they're doing good because they want to help you.
Yeah.
Thinking that a C-section is better because the cognitive dissonance of believing that it's not is too much for them to manage. There's no benefit to them in doing a C-section. It takes more time. There's slightly more risk. It interrupts their day. So what's the point? If I do a C-section at 7:30 in the morning on a Tuesday, I'm out by 8:20. I'm back in the office by 9. If I got twins, I might have to be there for 12 or 14 hours sitting around the hospital doing nothing. So why would I want to do that?
Yeah.
But so the thing with twins is that they shouldn't be taking care of twins. And here's another thing about my obstetrical colleagues, which I would be embarrassed by. I'm lucky because I trained in a time when breech was considered normal. But about 3 to 4% of term pregnancies are still considered to be breech. I think it might be even higher, but that 3 to 4% number is one of those numbers that's been repeated over and over again, and I don't really know. I don't know what anybody's looking. It might be less, it might be higher, but let's just say 4%. Let's say twins are 1 in every 32 pregnancies, so 3% of pregnancies are twins. Half of those twins are going to have a breech, so now we're up to 5.5% of all term pregnancies are going to have a breech baby. That's about 1 in 18. So as an obstetrician who's supposed to be an expert in all things obstetrics, 1 out of every 18 women that walk into your office who's pregnant, you're not qualified.
Wow.
You're not qualified.
Why didn't that like spark something in them to be like, I should become qualified?
Because they're employees.
I want you to know, though,
they're not individuals anymore.
Your class. So for those of you who don't know, Dr. Stu hosted a class like right next door about breech and twins, and it was awesome. I sent over 100 emails to OBs and doctors' offices. Like, I mean, that's where I was trying to do my because I was like, I want to like try to make an impact. Nothing. Got
crickets, right?
Nothing.
They're not interested. Part of it and the cognitive dissonance will say, well, I don't want to learn breech from that crazy home birth guy.
Yeah.
Right. I've heard that, and that's just an excuse. Name calling, by the way, name calling is the last bastion of a weak argument.
Yeah. Oh, for sure.
Right.
Yep.
Yeah.
So they don't want to learn it because even if they learned it, St. Francis or whatever hospitals around here aren't going to let them do it.
Yeah.
So why would they want to? Well, the reason you want to learn it is because in your career, you're going to have a woman that comes into the hospital with a butt beginning to stick out of the vagina, and you're not going to know what to do, and you're going to take that woman back to the OR, you're going to push the baby back up inside, you're going to give her general anesthesia, you're going to do an emergency C-section on her. Yeah, you're going to get nauseous from this, but you've been in another candle.
Right.
And you're going to do a C-section on her under general anesthesia. She's going to have no memory of the birth of her baby. And you still have to deliver the baby breech.
Yeah. It's just
you still have to know the movements and the cardinal movements of a breech baby to deliver it by C-section. Yeah. Some of the worst injuries of breech babies in major studies, like the crappy term breech trial, were babies born by cesarean section. Because doctors, you still have to deliver the baby breech, and they don't know how to deliver the after-coming head. Yeah. So they're yanking and pulling and yanking and pulling, and they get a brachial plexus injury or they get a neck injury. And they blame it on the baby being breech.
Oh my gosh.
And then that's why they say, thank God we didn't do this vaginally, because wow, we would never be able to get that head out.
Yeah.
At least with the surgery, I can cut a bigger hole.
Ooh.
This is what they think.
Oh my
Yeah.
gosh.
Because that's what they're taught, because they're not taught breech delivery. But how, as you as an expert in all things obstetrics, go through your career without knowing how to take care of one out of every 18 women that walks into your office?
Yeah.
That's crazy.
I would feel ashamed. I would feel upset. And you know who I'd be upset at? I'd be upset at my residency program. And
Yeah.
who's in charge of my residency program? Maternal fetal medicine doctors,
Yeah.
who are supposedly the high-risk specialists, who aren't teaching you
Yeah.
the tricks of your trade.
Yeah.
Yeah.
It's, you know, it is the blind leading the blind. And something needs to be done about it. And the demand is going to have to come from future medical students,
Right.
residents, and pregnant women and families and husbands. Going to need to stand up and say, listen, this isn't okay. You go to that first visit with your OB and you don't let them take your blood pressure, and you don't sign any forms, and you don't let them draw blood. You're interviewing them. As you said earlier when we were talking, maybe before on, you're the consumer. You're the employer. You're employing them.
Yeah.
Right? Ask them questions. And one of the questions you ask them is, what happens if I go past 40 weeks? What happens if I break my bag of waters and I'm not in labor yet?
Yeah.
And what happens if I have a breech baby? Are you skilled in breech delivery? Because you know what? 1 out of every 18 women at term are going to have a breech baby. And the doctor's going, it's that high? I didn't know it was that high. And they're going to say, well, no, I don't do breech delivery.
Yeah.
And then you look at them and you go, why?
Yeah.
And make them
Accountable.
answer the question. Accountable. Make them accountable.
Wow.
Answer the question. Well, I didn't learn breech delivery. Well, you know, Breech Without Borders or Reach Each Breech with Dr. Fischbein, they're teaching breech. They were just in your community. You could have taken it.
Leah harassed you. I sent you an email.
And by the way, I think about this sometimes too. I don't know of any other organization in the world besides me and Breech Without Borders. Thank God for Rixa and their team, who are going around the world teaching these skills. There are a few centers that teach breech delivery. There are a few residency programs that have either been teaching breech or have started breech. I think Breech Without Borders has gotten 4 or 5
Yeah.
hospitals to be doing breech delivery again. But 4 or 5 out of what, thousands and thousands of hospitals is not a great. It's a start, but it's not a great start. But if we were to stop teaching breech, there'd be nobody left to do it.
Oh my gosh. So do you have your schedule on your website of like where you teach breech? Because it's not just for care providers. You also like let families come in.
Families come, doulas come, any birth worker can come. Part of the reason that a lot of doulas come is, and they get to put their hands on and learn to do it anyway, even though they'll probably never do it. But they come because they're going to then advise future clients that say, when their doctor tells them this, they say, you know what, that's not true. You need to ask your doctor this. And so they know what's possible.
Right.
I admire people who are especially coming to my course and paying hundreds of dollars to come, who aren't actually going to make any profit from that, but are doing it because they believe in the betterment of women's health.
Yeah.
And that's why they're doing it.
Yeah.
My website has everything on it.
Right.
All my stuff is Birthing Instinct. It's birthinginstincts.com, and you can go to the events page and you can find out where I'm going to be next. And things get added on there as things get added on, obviously.
Yeah.
And then I have a thing called Work with Dr. Stu, where people who want to have a consult, whether you're a midwife or you're a pregnant woman and you think you're being gaslit, or you want me to go over what happened to you last time, you want to debrief.
Sure.
I do those sorts of things. The podcast is Birthing Instincts Podcasts, and you can find that at on any of your podcast apps. And also we have a website called birthinginstinctspodcast.com where you can have that. We have a Patreon group. We have over 1,000 members now.
Nice.
It's a nice community where you feel safe. It's behind a small paywall. There is a free membership level, and then there's different tiers
Right.
that you can sign up for, and you get extra content. We do a Q&A every month. We do a peer review every month, which qualifies, by the way, for your peer review
Oh, wow.
CEUs or whatever
wow,
you need.
okay.
Yeah.
We do I do deep dive once a month. Bliss does a village prenatal once a month where people come, and she does for an hour and a half. She talks about prenatal stuff.
Yeah.
So that's there. And then on Instagram, I'm Birthing Instincts at Instagram. I think that pretty much covers. I don't tweet, and I don't do TikTok as yet.
No, don't do it. Run away.
Well, it depends. The next generation of people, that's where you're going to reach them.
Yeah.
So I've been, my assistant, Raquel, who's great, is we're not pushing that hard, but at some point we're going to do that. I've written 4 papers on birthing, on home birthing, one on breech specifically, one on twins specifically. Those are also linked off my website. They're open access journals. You can get them for free.
You're changing
Small,
things.
small waves, small ripples.
Yeah.
But
And
yes.
It's impacting women and families just like us. So we thank you so much for being here, Dr. Stu.
It's a giant,
thanks for your time.
butterfly effect.
Yes, it is.
Correct.
I'm going to share a video with you after this, but thank you so much for being here.
Yeah, thanks.
Thanks, Irene. Thank you, Aaliyah. It's a pleasure being here. Thanks, Jacob. Okay, this is like, I feel like I'm on a professional set. That's kind of cool for me because, as I said earlier, Bliss and I wherever we're at, we're on our computers.
Yeah.
She's in her RV and I'm in my basement, and
that's great.
And that's where we do stuff. Or I'm in a club. When I go to LA, I stay at my ex's house because we're very close, and and I broadcast from a closet.
I love it.
Well, we're happy. We're thankful you're on here. So thank you so much.
Thank you very much.
Okay. All right, we got to get out so they don't get mad at us.
This content is for educational purposes only and is not intended as medical advice.
Please do your own research and find a trusted medical professional for personalized guidance and advice.
We are not responsible for your decisions based on the information you hear on this podcast.
Bye.
Bye.